Good morning, and welcome to our grand rounds this month for Southern Oregon. We're very pleased to have Dr. Annette Lopez from the Oregon Poison Center in Portland, Oregon. She completed her fellowship in medical toxicology and emergency medicine at Oregon Health and Science University. She completed her residency at Jefferson Health Medical Education, Jefferson Einstein in Philadelphia in emergency medicine. And she is board certified by the American Board of Emergency Medicine in emergency medicine and medical toxicology. And please help me welcome Dr. Lopez.
Good morning, everybody. I hope you can see my slides at this moment. Today, we're going to be talking about scromiting, which stands for scream vomiting, which represents cannabinoid hyperemesis syndrome. Just so you know, we are going to be talking about a lot of off-label medication use because there's nothing that's been FDA approved for the treatment of this condition. And we're going to talk about some objectives for today. We're going to talk about federal as well as state laws surrounding cannabis. We're going to talk about the pathophysiology that we think we know about cannabis hyperemesis syndrome, diagnostic criteria that's out there, how to recognize this clinically, and then talking about alternative diagnoses that we can consider to ensure that we're not boxing ourselves in. Finally, we're going to talk about what we can do in the emergency department and talk about treatment plans that are available. How about laws? When it comes to laws, nationwide, 24 states and 3 territories, which include Washington, D.C., have legalized marijuana for recreational use. And then there's 40 other states that allow it for medical use. So you're talking about a large region of the country that has some sort of indication for this medication. But there's a big nebulous legal status. You can start with the Controlled Substance Act of 1970, which scheduled marijuana as 1, which means it's highly addictive with no known medical use. That started to change when states started to legalize. There was a conflict between the state and federal laws that was represented by the Gonzalez versus Wright case in 2005. That particular case determined that Congress and the federal government are able to regulate and prohibit local cultivation and use of marijuana, even when it's in a local where local law allows it to be grown. Now, in August of 2013, the Department of Justice decided that it's not a priority to prosecute folks who are doing legal medical marijuana. However, there's a caveat in that they can actually still enforce that. In October 2022, Biden ordered a review of marijuana and its scheduling, which came back in August of 2023. And the recommendation at that time was that it could be moved from a Schedule 1 to a Schedule 3. And that falls in line with things such as ketamine and steroids. In May 2024, the Drug Enforcement Agent proposed a rule that would finalize that move. And that was pending lots of hearings, which were postponed for multiple times, but we finally have a date of January 29th, 2026. Then comes December 2025, and that's when Trump released his Increasing Medical Marijuana and Cannabidiol Research Executive Order, which directed the DOJ to complete the rescheduling move that had taken place. Now, I keep talking about scheduling moves. And if you see on the right, we have a drug schedule. Marijuana falls currently, well, non-state marijuana falls under Schedule 1. And that's, you got heroin, you got LSD, you have peyote. Schedule 3, which is where we're moving to and technically have moved to, you have Tylenol with codeine, you have ketamine, you have steroids, you have testosterone. But what does that really mean? Well, we're kind of still in very nebulous territory. It definitely means that it will not be legal for recreational purposes, only medical purposes. And we don't really understand yet what the impact is going to be for the state marijuana laws in its basis. There's questions about what happens in folks who have requests for reasonable accommodations under the American with Disabilities Act, since it is a medication. In the past, it's been rejected at the federal level. And then the question is, what about employers? Currently, marijuana is under the Schedule 1 when it comes to testing through the Department of Transportation, which is the one that does all of your employee drug screening. And there have to be changes to all of that in order for that to no longer be the case. Now, flashing news, April 23rd of this year, the acting general actually issued a final order. In this particular final order, what has happened is that we have officially moved FDA-approved products that contain marijuana and marijuana through state-approved medical programs to Schedule 3. That means that they believe they're subject to abuse and harm, but there is a medical value. However, they need to be taken under supervision of a licensed professional. If you're not within an FDA-approved product or a state medical program, you're still considered illegal. The state entities that have state approval have to submit credentials to the DEA for federal registration. Now, the caveat to this is that now prescribers and pharmacists are going to meet to DEA requirements in order to prescribe and dispense these medications. This could actually mean that dispensaries will have to have a pharmacist in order to dispense a medication. Still, no legalization for recreational purposes, and it also excludes synthetic products. The biggest win out of this current breaking news is that businesses that have medical marijuana now qualify for business protections when it comes to tax purposes and the use of. Now, let's talk about what recreational marijuana laws in Oregon. This has been going on since July 1st of 2015. You have to be 21 years old, and you're going to be restricted by daily purchases and how much you can have out in public. This does not exclude your employer from testing you. You should not be using it in public spaces. You also should not transport across state lines. That actually proves very important because last week, the TSA actually released guidance for their TSA officers that basically allows you to bring marijuana products in planes, but it's subject to local statutes. So if you were technically to fly from a marijuana-friendly state to a marijuana not friendly state, the FAA, the folks at TSA could see you there and report you to local officials because it's not considered legal in that region. Now, finally, when it comes to recreational marijuana Oregon laws, there's taxes associated with it, and then they're collected by the Oregon Department of Revenue. Now, medical marijuana laws in Oregon. You need to be a resident, and you require a driver's license. If you don't have one, you can use a state ID. They even give you the option that you can bring in your utility bills. You have to be aware that if you change your name or you move locations, you have 10 days to let them know that. And it's actually not very cheap. It's every year. If you have no supplemental nutritional benefits, you're not part of the Oregon Health Plan, you're not a veteran, you're paying $200. Those folks who have SNAP gets you $60, OHP gets you $50, you're a veteran or you're collecting disability benefits, you're down to $20. And if you decide that you're not going to grow your own marijuana, you're going to have someone else grow it for you, they also have to pay $200. Now, the medical marijuana laws actually limit how much can be grown or purchased, similar to the recreational laws. An exception is that it allows minors to use marijuana with a primary caregiver declaration. There's no tax associated with this, but you're still required to bind to employee requirements as well as landlord requirements. You can't ask your landlord can tell you, hey, you can't smoke in the property, and that's not a violation. And your employer can still test you for. This is what needs to be filled out as part of the Oregon law by an attending provider. Now, you don't have to fill this out. You can actually provide the patient with relevant portions of the medical record that would suffice with the information that's needed there. And who's an attending provider? Up until 2022, it had to be a doctor of medicine or a doctor of osteopathy. However, in 2022, changes were made that allows a physician associate, a nurse practitioner, a clinical nurse specialist, certified registered nurse anesthetist, and a naturopathic physician to actually fill out these forms. And who actually qualifies as an attending provider? Well, the easiest way is you're the actual primary care provider of that person, and you've been the one that are treating and diagnose that person with a medical condition. Now, you could also be the specialist that's caring for that person and treating that person. And here's where it gets kind of dicey, is you can be a consultant for that person, but that consultant has to be asked to examine and treat the patient by either a primary care physician, their physician assistant, or nurse practitioner. So there has to be a medical communication between the primary care provider and that consultant. This becomes a little tricky because there are some practices out there that solely sell medical marijuana cards. And it's very important that you reviewed the patient's medical record, you actually examine the patient, and you have a plan for follow-up care for that patient, and that you actually have a written medical record somewhere. And then the process is pretty simple. If you meet the criteria, you get the paperwork filed, you either do it online or by mail. Once the program receives all your complete information, they will send you a receipt that's good as a card until you get your card, which usually is within 30 days. If your application is not complete, they just sent you a letter. If you don't provide the new information within 14 days, you've lost your application. Now, the reason I've gone over all of this law is because it's going to become really important as things sort of transition, and we don't really know how this is all going to peter out over the next couple of years. And some of people are going to be coming to you now to make decisions where we don't quite have a framework out there other than our state medical framework. So we have changing times. Turns out marijuana use is on the rise. About 2.5 to 5% of the population uses it regularly. In the US, you're looking at about 18% of them have used it at least once. And there's the Monitoring the Future report, where they actually take data from teenagers, and there's increasing use of marijuana. And it's used for a whole bunch of medical conditions: appetite stimulation, HIV-associated anorexia, seizures, glaucoma, headache, chemotherapy-induced vomiting, chronic pain, spasticity. You can add a whole bunch depending on the state that you're talking to. So what's cannabinoid hyperemesis syndrome? Turns out it was described in 2004 in South Australia, and it was syndrome of cyclic vomiting in the setting of chronic high doses of cannabis that was associated with people feeling better after taking hot showers or baths. Turns out that our neighbor in Colorado, after legalization, the rate of presentations with this doubled. There is a delay in onset because you have to consume large doses over a period of time. And so far, we've been able to look at emergency department visits. And from 2017 to 2021, there's been 2.75 million of them. And if you start asking folks who consume cannabis daily, almost 20% of them have some form of this syndrome. Now, as of October 2025, there's an actual ICD-10 code for this, so it'll be easier to get some data in the future. Turns out these folks have frequent multiple presentations to multiple settings, the most common ones being primary care physicians or the emergency department. And if you look at records, they have undergone extensive negative testing. Some data suggests that they may have the mean number of CTs is 5.3 plus or minus 4.1 associated with their presentation. And when they show up to the ED, they can have huge cost, especially when they get admitted into the hospital. In some studies, anywhere between $62,000 to $268,000 over the time period of the study. Most of the admissions were related to symptom control. And it turned out that there was delays of 1 to 2 years prior to the diagnosis. Now, I don't know that's much of a problem here in Oregon, since most folks tend to be pretty open about their marijuana use, but in places where marijuana is not as ubiquitous and not legal, there's stigma associated with, so people might actually not tell you that how much they're doing. A lot of people won't mention it because marijuana treats nausea and vomiting, so it's part of their treatment, and they don't see it as the cause of their symptoms. So how does it work? So we have receptors in our body, the human cannabinoid receptors, because we actually have intrinsic cannabinoids that are produced by our body. The one that we're worried about is delta 9 tetrahydrocannabinol, because that is what causes psychoactive effects from marijuana. And that one's going to react with our CB1 receptors. They're found in our central and our peripheral nervous system, and they tend to give our psychoactive effects. We also have CB2 receptors. Those are found in the immune system. They're actually meant to have immunomodulatory effects. They're not per se affected in this setting that we're aware of. So THC is meant to, people think of it as an antiemetic. We actually don't really know a whole bunch of how that actually works. There's thoughts that our endogenous or natural cannabinoids are involved in the emetic circuits in the body, particularly in the brain at the cerebellum, the hypothalamus, and the medullary vomiting centers. There's a belief that since we've been increasing the THC content in marijuana, there are some products that are available at greater than 95% content. We have activated the CB1 receptors. And those CBD1 receptors developed a dose-dependent relationship. So at low doses, you prevent vomiting. High doses, you actually potentiate or make vomiting much worse. And then there's data that THC can be a pro-emetic. Again, unclear mechanisms. Some of them are that you downregulate the CB1 receptors, therefore you're not controlling it. There's some thoughts that because marijuana loves fat, you actually store fat in fat. And when you are in times of stress, you start breaking down your fat, you actually release that marijuana, and then you cause more damage. There's thought processes that some folks have cytochrome P450 that leads to the metabolites that are causing nausea rather than the parent product. There is some thoughts about delayed gastric emptying, although that only has been shown in 30% of folks. And then the other thought is that you're actually stimulating the endogenous CB1 receptors in the gut, which then causes splanchnic vasodilation, and you increase vagal discharges, which then lead to the sensation of nausea and vomiting. How do we go about diagnosing this? So for the most part, this is a clinical diagnosis. You're looking at young patients, typically under 50, although I can tell you it's present in folks above 50. It tends to be about 72.9% male predominance. And they have what folks consider a long history of THC use, but that's actually described of more than 1 year and once a week, which that around here is sort of considered a pretty low dose. They develop severe cyclic nausea and vomiting, compulsive hot showers and baths, and they may have things like diaphoresis, bloating, abdominal pain, flushing, weight loss. So there's been sort of a development of clinical criteria. The initial one was you had to have long-term cannabis use, a year or more, at least weekly. And then you should have cyclic nausea and vomiting, gets better when you stop cannabis, hot showers and baths sort of help you feel better. And then you lose weight, so it's a significant problem. And we're talking about 5 kgs. Mornings tend to be a significant time for symptoms, which kind of makes sense because you have that period of fasting. You maintain normal bowel habits, and all of your imaging looks negative. Then The American Gastroenterology Association has proposed more stringent criteria, starting with the Rome 4 criteria. So you need to have stereotypical episodic vomiting that looks like cyclic vomiting syndrome. Well, what's the definition of that? You have vomiting that's acute in duration. You have at least 3 distinct episodes in the prior year, 2 episodes in the past 6 months, at least 1 week apart. And then you have no vomiting episodes, no vomiting between the episodes. Now, when we're talking about cannabis associated one, where you have to have used cannabis for a long time and you get better when you stop your cannabis use. And they've sort of declared 4 phases to the presentation of cannabis hyperemesis syndrome. You have a prodromal phase. Patients appear anxious and agitated. There's almost like a sympathetic response, which then leads to sweating, flushing. They have an incredible thirst and they sort of feel like panic or out of control. They start developing abdominal pain that tends to be epigastric but can be diffuse, and they have severe nausea, similar to morning sickness in the morning and when they see or smell food. They don't start bathing yet, and it's a short course before they go on to develop the syndrome. And the reason that this is important is because we can actually use abortive medications. And what they're using are triptans, so similar to migraine management, or antiemetics. And the most important and new one in the picture that they're talking about here are the neurokinin antagonists. So that's aprepitant, fosaprepitant, netuprednisolone, and rolapitant. These are used in chemo, and they're chemo nausea drugs. And then they also talk about our usual H1 antagonists and benzodiazepines. You then go on to develop the emetic phase, and this is probably what most of us are going to encounter. You're going to have incapacitating nausea and vomiting. Comes out of nowhere other than associated with the prodrome. You do ondansetron, you do promethazine, these people aren't getting better. Then they report that the only time I feel better is after I take a shower, which leads to them taking multiple showers or baths to the point of them having burned their skin. They can have a low-grade fever, continue this excessive thirst, but at this point they can't keep it down. And then that's kind of where you get the vomiting associated with this and the screaming associated with this. They develop orthostasis. They may have abdominal tenderness. And they actually report feeling better immediately after vomiting, which leads them to try to vomit. So they constantly are gagging themselves. And then hopefully we get them to a recovery phase. This is sort of the final active phase. May take 24 to 48 hours, depending on sort of what interventions are done. The most important things is giving some bowel rest, advancing the diet as tolerated, ensuring that fluids are given, keeping track of electrolytes, and most importantly, stopping marijuana use. And during this phase, they can start regaining the lost weight because for the most part, it's going to be water weight. And then there's a potential inter-episodic phase. So in between all of these episodes, patients have minimal symptoms. Most likely is going to be a little bit of a dyspepsia. And then this is when you can consider prophylactic medications. We're talking about tricyclics. There's some use on anticonvulsants. Levetiracetam and sonezumide are the sort of the ones that are out there in studies. And then there's very small studies which look at mitochondrial supplements, CoQ10 and vitamin B12. And then again, this NK1 antagonist, sort of the prototypical drug being aprepitant. Why the compulsive showers and baths? I don't know if you remember back, but we talked about splanchnic circulation being affected. Honestly, the one that makes the most sense is the cutaneous stele, or you end up with vasodilation when you take a shower, which then steals blood away from all of the GI tract that is being flooded and sort of helps control the symptoms. There's also thoughts that there is an effect on the CB1 receptors in the hypothalamus. And that sort of disrupts the process that's going on that's leading to the symptoms. And then there is some thought that THC has hypothermic effects by changing the set point. Through the hot shower, you're changing your symptoms. But honestly, we don't know. What should you think about when it comes to a differential for this patient? So if there's no marijuana use, things like cyclic vomiting syndrome and psychogenic vomiting is something to think about. Obviously, you need to get a good marijuana history. You should ask about hot showers and baths. And then make sure you don't forget about the things that are going to hurt or kill people. So is this medication adverse effects? Is the person pregnant? Are there other toxins that we need to think about? How are their electrolytes? Are there any neurological abnormalities? Are there any endocrine abnormalities? And are there any gastrointestinal emergencies that we need to think about? So what's a practical diagnostic algorithm? Well, get a history, get a physical. And is there a severe underlying medical condition that sort of looks more likely? If so, go that route. Ask the person, are they taking hot showers or baths? If they're not, sort of keep looking at other alternatives. If they are, sort of ask why. Do they feel better? And then sort of, are you using marijuana? Some folks are going to tell you, some folks are not. This is probably one of the rare circumstances that I would recommend to check a urine drug screen, because they will have THC in their system. The folks who abstain from marijuana in the context of this will test positive for a very, very long time, because you're releasing it from your fat stores and you've had a huge consumption leading to this. Are they volume depleted? Are you able to take fluids? Because if you're able to still take fluids, give them oral fluids. If they're not, start IV hydration. Do the symptoms get better when they stop marijuana? This is a hard question because a lot of our patients don't believe the marijuana is causing this. But if somehow you're able to get them to stop, that would be great. And then obviously, if they're not using marijuana, this is unlikely what the cause is. What should we do in the emergency department? You want to get a chemistry. These folks potentially have been vomiting for a while and their electrolytes could be abnormal and they need replenishment. Look for other things. What's their liver function looking like? What's their lipase looking like? Are they pregnant? And an EKG is critical for these patients, not just to diagnose their heart and electrolyte abnormalities. The treatment that we're going to give these patients is highly going to depend on what their QTC is looking like. So if you have very prolonged QTC, you're going to be limited on interventions you can do for those patients. And when it comes to imaging studies, if these are repeat offenders, only repeat imaging studies if you really think there's an emergent cause. Otherwise, please be very aggressive, because as you saw earlier, some of these folks have gotten 9 to 10 CTs prior to actually getting a diagnosis. What do you treat these patients for? So first and foremost, you want to make sure aggressive fluid hydration, electrolyte repletion. These folks are probably in acute kidney injury, and we need to make sure that we address that. What are some out of the box things that you can try? So back in 2021, there was a case report and case series in which they talked about capsaicin, and that's capsaicin creams, and anywhere between 0.025 to 1.25% that's applied topically to the abdomen. Just like you apply Bengay, you kind of rub it in your belly. And the way that that works is by activating the TRP1 receptors. It turns out that those receptors interact with the intrinsic endocannabinoid system, and you are going to deplete or inactivate substance P. Substance P actually competes with THC in stimulating those receptors. And it turns out that capsaicin rubbed in the stomach, patients felt better. They were able to discharge quicker after its administration, but unfortunately didn't change the number of medicines they received or how long they stayed in the emergency department in total. Personally, I've seen it work in some folks, and it's worth a shot. Haloperidol. Case reports, anywhere between 1.25 milligrams to a weight-based dosing that uses 2.5 if you're less than 80 kilos and 5 milligrams if you're more than 80 kilos. It's actually believed to work by blocking postsynaptic dopamine receptors in the brain. Turns out that THC increases your dopamine, and then there's turnover and efflux and cell firing. You decrease the effect of dopamine, you actually stop the chemoreceptor trigger zone, and then you decrease how much input is going into those medullary centers. And folks have felt better. I've been able to discharge folks after Haldol administration. And there's actually psychiatry case reports in which folks were discharged in oral home dosing and they continued their THC use. Then there's droperidol and napsine. A lot of the data for this is non-peer reviewed online sources. There was a significant cut in its use due to its QTC prolonging effects, and for a time it was banned, which resulted in not much availability. But there are two retrospective reviews. One was at a single tertiary metropolitan hospital. They used 0.625 to 5 milligrams IV, and folks almost discharged half the time compared to folks that didn't get this medication. And about half the time the folks got droperidol and then resulted in their discharge. Then there was a second retrospective review, 2 tertiary academic centers in Georgia. They actually use half the dosing, so 0.625 to 2.5 milligrams, either IV or IM. They sort of theorize that it's the same mechanism as haloperidol. And then they warn that you got to be careful with electrolyte abnormalities of prolonged QTC. But you had a shorter length of stay. You required fewer opioids. We'll talk about how that wasn't a good thing. And then fewer total medications. And then of note, there were some akathisia and dystonias, which would be expected with the medication that you're providing. Now we kind of move on to some different things. You got the atypical antipsychotics. This is olanzapine or Zyprexa. The good thing I like about this one is it's available in a sublingual formulation. So you bypass gastric absorption. You put it on the person's tongue, that medicine's on their system. You can do 5 to 10 milligrams. It already has an FDA label indication for chemotherapy-induced nausea. And the mechanism is similar to Haldol and droperidol in that it inhibits dopaminergic, serotonergic, adrenergic, histaminergic, and muscarinic receptors. So all of the things that go on the brain that can lead to vomiting, this is inhibiting. There's case reports of outpatient short courses into clearance of the marijuana. I personally have done this in like very specific patients who are willing to quit and understand that this is happening. The good news about this one is that it has less extrapyramidal effects and you don't have to worry about QTC prolongation as much. Still have to worry about it, but not as much. And now we're to the newest drug, one that I've mentioned all along, and we're talking about aprepitant. Turns out there is way more pediatric literature for this. And by pediatric literature, we're talking about mostly teenagers, then there are adult cases. So with pediatric literature, there's a case series, so 2 patients, followed by a retrospective review in which they actually looked at cyclic vomiting and then hyperemesis cyclic vomiting. Turns out there was 88 children, 34 of those had cannabis hyperemesis associated vomiting. And of those that receive aprepitant, 97% got aprepitant, and then 84% of them had improvement. There is one adult case report where they were failing all of the standard treatments. They got a dose of aprepitant and they were able to discharge symptom-free. How does aprepitant work? Well, it is neurokinin receptor 1 blocker, and it works with substance P again, similar to the TRPV1. This is present in the brainstem nuclei of the dorsal vagal complex and is responsible for regulating vomiting reflex and neurochemical responses to stress. You block the NK1 receptor, substance P is unable to bind, and you control nausea and vomiting. Great, that sounds amazing. Well, one pill runs about $80 for the 125 milligram dose. And that gets given on day 1. And then on day 2 and 3, you take 80 milligrams pill, which is worth about $46. and then you do it 2 times per week until symptoms get better. Of note, it takes an hour for it to work, but you must control the vomiting first. So you got to be able to keep this medication down. There are IV formulations, unfortunately, not a huge, still expensive, and a lot of places are restricting who can use them. Of note, Minnesota Children's uses aprepitant as their first line of treatment in CHS for teenagers. Narcotics. I already talked about how these seem like a bad idea. The expert opinion is to avoid them altogether. You're going to develop bowel dysfunction. These folks were vomiting and had normal bowels. Now you're doing vomiting plus constipation. So it can actually make things worse. And then you're going to get stuck in a cycle of dependence. Given the frequency that these patients present, they're going to get lots and lots of narcotics, and then they're not going to. And then you're going to get stuck are they in withdrawal from narcotics, or they're having an episode of their cyclic vomiting? How do you take care of these folks long term? So there's thoughts on using tricyclic antidepressants. Amitriptyline is sort of considered like the mainstay agent. You start at 75 to 100 milligrams at bedtime. Ideally, you want to titrate from 25 and see if they get better. And then capsaicin, topical, 0.1%. You probably want to build up to the 0.1%. So start with the 0.025% and then slowly go up. You apply it to the upper abdomen and you can actually reduce antiemetics. But your definitive treatment, the thing that is going to stop this, is stopping the weed. So there's reviews of published studies, 62 out of 64 patients who remained abstinent had improvement in symptoms. And the 2 that didn't have improvements were never quite able to clear whether they were abstinent or not. So what can you do until folks are abstinent? We talked about how marijuana gets stored in fat cells, and there's actually a very delayed action and release of that marijuana. Folks can go cold turkey. They will tell you that they're withdrawing. Just so you know, marijuana does not have a true withdrawal syndrome. It actually has a drug discontinuation syndrome. You never actually develop dependence to THC, but you still have feelings associated with its removal. And unfortunately, you have a high frequency of recidivism. Amitriptyline has been used to sort of bridge folks. And then, as I mentioned earlier, there's some case reports of both haloperidol and olanzapine as a bridging agent. And there's some preliminary evidence of small placebo-controlled trials in which fatty acid amide hydrolase inhibitors can be used, but that's kind of needs a whole bunch of more studies to get to the bottom of this. So how do you take care of these patients? I kind of tried to modify this and be it applicable to when you're out in the field. So you have a patient that presents with cyclic vomiting. You're gonna just sort of get them treated. So get some fluids on them, get antiemetics on board. I prefer ondansetron and followed by metoclopramide because that one actually has got motility effects. Some diphenhydramine, and then depending on what's going on and how you feel, some lorazepam. All of those agents have antiemetic properties. And then I ask them, are you using marijuana? They tell me yes. Then we go and we try some capsaicin. If they get better, then they can go home with capsaicin. Honestly, they're probably not going to get better. And then I start considering antipsychotic doses. And then this all depends on what you have available in your department. Do you have olanzapine? Do you have haloperidol? Do you have droperidol? What is your department and pharmacist willing to do for this? So consider one of those, pick your poison, and then see, are they getting better or they're not? If they're getting better, I would discuss with the patient that they need to stop using marijuana because that is most likely the reason that they keep coming back with the cyclic vomiting syndrome. If they're not getting better, this is when you want to chat with your pharmacist and consider a Prepitant. I know at the hospital I work at, that is not going to be something that I can use. However, at some locations, that might be something that you can use. So in conclusion, we have a higher prevalence of chronic abuse for THC due to recent legalization. And it's only going to get worse in the coming years as people are seeing this as a medication rather than a substance abuse issue. And will be asking us for prescriptions for this because technically prescriptions can be written. So I suspect in the next couple of years, we're going to have a huge increase in the number of patients that we're seeing for this. You have to have a pretty high index of suspicion if you have someone who keeps back with recurrent vomiting and you don't have a etiology for it. Make sure you ask THC use, and then not just smoking, we're seeing it with edibles too. And then ask them, are you feeling better with hot baths and showers? Honestly, you can potentially avoid unnecessary workups if you identify this right off the bat and they otherwise look well. And then, you start with conservative management, make sure you get lots of fluid resuscitation, and then trying to convince these patients that stopping THC is the true cure for this is hard, but if you're able to, they will have improvement in their symptoms. All right, I think this is a great spot for us to have some questions because I'm sure there's a ton of them out there.
Okay. I had one. How many referrals? Do you give referrals to GI specialty if the patients just have just intractable symptoms? Is this something a specialist could follow up on, or do they just follow up with their
So I usually
family
tell them
medicine?
to follow up with their primary care physician. My experience has been sort of twofold. There are some folks that I'm able to bring in. There's actually some really good literature out there. I want to say Mayo that talks about cannabis hyperemesis and sort of breaks it down for patients. And I'm like, hey, here's some information on this syndrome, and this is what I think is going on. And I'll tell them like why I think it's happening. If they buy into that, I've been able to sort of I've done some bridging. I have done the olanzapine bridge to help them get through. I have not done the amitriptyline just because I am not a huge fan of tricyclic antidepressants. Olanzapine, I really like because of its sublingual characteristics. I can send them home with that, and I know that even if they're throwing up, they're actually going to be able to keep that medication down. And I've only done like a week's worth of the medication, and so far that has worked in the couple patients that I've used it. And the ones that are resistant tend to want to have the $1 million workup. And unfortunately, those folks, I personally have not referred to GI. I kind of want them to follow up with their primary care doctor and they can have a close discussion with those folks. Because for the most part, most of those folks don't need the $1 million workup. And honestly, I think in order to, if you're actively using large amounts of marijuana, in order to get that $1 million workup, you should totally like be off the marijuana and still have symptoms. Does that kind of make sense?
Mm-hmm. Yeah.
And I work in a closed system, so I can forward my note to the PCP and I can write a little like FYI, this is what I think is happening. this is what I've done for the patient. And so far, the primary care doctors have been pretty receptive about that intervention.
Do you know whether practice guidelines are being established?
So the ACA has practice guidelines. They're the ones that talk about using amitriptyline, and they also talk about capsaicin are sort of the two agents that they use. Unfortunately, when it comes to toxicology, it's really hard to do randomized double-blind controlled trials. And usually what ends up happening is that a medication gains favor, and after a while, it's sort of considered standard care, even though it hasn't gone through that rigorous testing. And I think that's where we're going to get stuck with this one, where Haldol's already been shown that it works, and droperidol has been shown that it works. So it's hard to like withhold those medications to give someone placebo.
I'll give it 4 minutes. That was an excellent presentation. Lots of information. Very helpful information. We're so
And
thorough, there may not be any questions. There was a lot of information there.
yeah, it'll be interesting to see what happens with the federal level versus the state level. It'll be interesting because they're making it seem like they're going to want pharmacists at the dispensaries because it's now a medication, and medications are dispensed by pharmacists. So that might actually do a huge shakeup in the industry. My other concerns that I have when it comes to the industry is that a lot of, at least in Oregon, dispensaries are doing both the recreational business as well as the medical business. So now medically, you're going to be registering with the federal government and telling them, I am a dispensary for medical services. At the same time, you're going to have your recreational, which now means the DEA has the FDA will have, and the DEA will have records of you being a provider. So they could potentially show up and then get you for the recreational part because that is not legal. So it's going to be a conundrum when it comes to you registering because now you're basically giving information. And if you have a recreational business, that might get you into trouble long term.
Do you predict that if that does happen and pharmacists have to oversee prescribing this, that there will be an increase in users pursuing nefarious avenues around that?
Well,
Without a dispensary, a licensed dispenser?
I suspect that what's going to happen is there's going to be there's a ton of dispensaries around. We don't have we don't have pharmacists right now for our current operations. Like, let's be honest. So I suspect that there's going to be some choices that are going to be made by the industry. And I don't know that we can support the number of dispensaries that are out there, at least from the medical perspective. But in order for you to qualify for the tax incentives and all of that sort of stuff, it has to be through the medical perspective. And now it's really interesting because I would love to find out what's going to happen. Oregon restricts you. It has to be a local purchase. You're not supposed to cross state lines with your marijuana, which is, in Oregon, you can theoretically cross state lines rather easily with your car. Not as easy sort of in the middle of the country. But then now with TSA saying, hey, we're going to let you use your medical stuff as long as it's within local backgrounds. I hesitate to see what that's going to end up being if you land in some place in the middle of the country that it's illegal.
That was an interesting piece of information you shared. Yeah.
Yeah, and that just happened last week.
Wow.
I actually saw it last night as I was getting stuff together. I was like, oh, wow. Now, TSA doesn't per se care as much anymore, but they will follow local regulations, which here it doesn't mean much, but it will mean something in other states.
Oh, yeah. Yeah.
And I could see where more restrictive states will like totally capitalize on this and go after.
Oh, yeah. More enforcement. They already are doing.
Because that's unfortunately, I mean, if you actually look at the history of making marijuana illegal, it was very much a racist decision. It was sort of used to keep down the Mexican trade of marijuana and all of that sort of stuff. So I could see where they could use that to incarcerate people and that sort of stuff.
How prevalent is this syndrome in restrictive states? Are they still managing to come in
So
and be sick with this?
they are. I suspect that because people aren't willing to cooperate and give that information, it's underreported in non-legal states. And honestly, up until October, we didn't really have a reliable method of figuring out where it was. So before you had to code it as nausea, vomiting, and then you had to put in THC as either abuse, misuse, or a second. So you had to tie them together, and that might not have been done through coding. In October, we actually have cannabis hyperemesis syndrome as a code. So I suspect that 2025 data forward, if it's coded properly, we'll have a much better and a much more reliable way to track these numbers.
Could you share the codes that they've established for that?
I will.
Very helpful for our providers. They may not, that may not have hit their radar.
R11.116 is the actual ICD-10 code for cannabis hyperemesis.
R11.
Point or period 16.
Okay, good to know. And it's just called.
It is cannabis hyperemesis syndrome as the actual diagnosis code.
Great.
And that would be very helpful in sort of helping figure out the true incidence of this going forward. And it also could actually be helpful in repeat visits, because I personally have been a lot less imaging happy in these folks. And I will try as many interventions as possible before I consider imaging. And honestly, usually imaging is sort of done just prior to admission to make sure that I'm not missing something before I admit someone.
Okay. Would it be helpful for you? I don't know whether this can be done. I'm a layperson, but is it helpful to the Oregon Poison Center to report how many times they diagnose?
So we love
and track data.
We love getting phone calls, even if you know how to manage a case. I actually personally, on my emergency room, will call the Poison Center and be like, hey, I'm calling to let you know about this person. I'm doing XYZ, which is what I would do when I'm working at the Poison Center. But our numbers lead to our funding. So the more phone calls we get, even if we're doing minimal recommendations or sometimes no recommendations, you called us when we request funding, we can say, hey, we have these many calls. So the actual call volume helps. I also like to call the Poison Center when I'm working with a patient and I've made my recommendations, because then I ensure that someone's following up on what needs to happen next. Sometimes along the way, things might get lost in conversation, and there's pretty strict protocols on how you manage particular exposures, and they'll make sure that the things that need to happen and that doesn't get lost along the way. So please feel free to call us. You might have to wait a little bit if a lot of people are calling, But I think from our funding perspective, it will allow us to be here so that we can do things like this in the future.
It would be really great if Oregon could develop an online report tool for providers. I mean, that's a lot of make it easier, and you might get more
I will
providers.
pass it. Yeah, I will pass it along to
It just
our.
popped into my head. Just might be a good idea. That way, it bypasses, waiting on the phone or leaving a message. And yeah,
Now, something that's too, when you guys call us for any sort of exposure, is that our databases are actually mined by the CDC,
mm-hmm.
and
Oh, okay,
and they actually look for patterns. So if all of a sudden there's an increased number in diarrheal illness or vomiting or something that keeps coming up, they can actually sort of prospectively consider, like, hey, have you guys noticed this? And what do you know about it? So that also helps public health perspective.
that's great because then they can surveil it that way.
Yeah, so we have that. There's
Lovely.
active surveillance through our,
Okay,
our calls
that's
and
good
our
to know.
codes.
That's really good to know.
Particularly, it comes up when like new drugs make it to the system. Luckily for us, we're not in the pipeline of new drugs. Uh, New drugs actually tend to start in Europe. And by new drugs, I mean sort of like the designer drugs. They tend to start in Europe and migrate to the East Coast and then sort of make their way west. So we technically don't tend to be in the forefront of new drug manufacturing. We're pretty set in our ways. Meth is sort of king in this region. Cocaine apparently is making a comeback in the region, which is not something that I ever thought possible. But if for some reason we happen to hit a bad batch or something, these prospective surveilling can actually let us alert people about it.
That's a good point. Okay. Well, thank you, Dr. Lopez. This has been a great discussion. Wonderful information in your presentation, and uh, I I will make sure that I put information for how to reach you if they have further questions
Absolutely.
in the chat, and yeah, I'll attach that to the recording as well.
All right. Well, you guys have a wonderful
Thank you
day.
so much. We
Bye,
appreciate
everybody.
all of the time. Thank you.